Hi, everyone. Hi, everyone. Welcome to the Climate Change, Disability, and Rehabilitation Workshop. Today is our last session, and today's session is going to be focused on how healthcare providers can be part of the solution. We invite you to go back and view the other sessions online if you have not seen them. They've all been quite educational, and we will share the link in a couple of seconds. Today, again, our topic is healthcare providers can be part of the solution. And just a reminder, I am Dr. Markalee Alexander. I am the president of Sustain Our Abilities. And our partners in this webinar series are the Global Consortium on Climate and Health Education and the International Society of Physical and Rehabilitation Medicine. Today's agenda includes following speakers: Dr. Anne Christine Duhame, Dr. Caleb Dresser, Dr. Eric Lewandowski, and Dr. Anita Lowe Taylor. And I'm going to let them all introduce themselves because they're going to explain to you the story of how they got involved in climate change and health, and why I think it's really important for you as people attending this meeting to get more involved in climate change, in health, and in rehabilitation. All the recordings are available on the website, and for questions that you may have, the link is in the chat now. There is also closed captioning available for this webinar, so please access it if that is a need of yours. We want you to put all your questions for the speakers in the Q&A, and we invite you to keep your cameras on. Based on attending this course, we do have one goal for you. These courses are all complimentary, and there's a lot of work behind it. So a lot of people put a lot of work into this, and we do have one request for you as attendees. We would like you to take one action and think about it if you haven't already figured it out based on the first three presentations, but take one action related to climate change, disability, health, and rehabilitation. One action in your sphere of influence, which might be talking to friends, colleagues, doing something in your community, doing something in your professional organization, getting involved more in the organizations presenting these talks, but do it and do it in the remaining months of 2022. If you want to learn more about what we do, sustainourabilities.org, there is the URL, and the Journal of Climate Change and Health. Many of our speakers have been involved in the Journal of Climate Change and Health and have written papers that are there, and we are doing special issues related to health disparities, climate change, and ethics of health, and also a special issue on the state of medical specialties and climate change in the upcoming year. And we will also be following through, and this is the first time I'm announcing it, with a climate health course, a 2-day course in 2023. So think about putting that on your calendar now, October 20 to 22. And I am going to now stop sharing my screen, and I am going to turn it over to Dr. Duhame for her presentation.
Okay, sorry folks for those technical difficulties. I am Tina Duhame. I'm a pediatric neurosurgeon at Mass General and also the Associate Director of the Mass General Center for the Environment and Health. I got into this business of climate change some years ago, but immediately it's been through the Journal of Climate Change and Health that Markley mentioned. Okay, so Haley, I'm gonna need you to advance the slides, I'm afraid. Okay, so what we're gonna cover in this talk is a little bit about how I got involved in this, and you know, examples all of us would give is how people in the healthcare profession that are not related to climate change might get into that realm. And as you can see around the corners of this slide, these are the sorts of things that I do in my professional life. Although very recently I've sort of tapered off some of this clinical work to focus on climate change because I think it's a critically important problem. The way I got into it is through, as you'll hear from Eric Lewandowski, the intersection between brain behavior and climate change. And really, climate change is about the choices we've made as humans. And how we make decisions and how we make choices has long been an area of interest of mine, which is one of the reasons I have focused in pediatric and functional neurosurgery as well. You'll hear a little bit more about things that have happened at my institution along these lines that may be things that you have already started to do or that you will do at your own institution. So one of the ways that we get involved in this is through our own hospitals and recognizing that there is a big problem out there with climate change, that it does affect human health, that the healthcare sector may have its own role. We do contribute to the problem, and we're going to talk a little bit about that in this talk. And as Markley mentioned at the beginning, what can we do about this? Does anything that we do in our professional lives make a difference? And then we'll talk a little bit about next steps. Next slide, Haley, please. So we've all had to learn new vocabulary about this whole issue of climate change because we didn't learn this, at least I didn't learn this in medical school or the undergraduate years. Some of you who are on this call probably took courses in environmental science or have kept up with this in the lay literature, but you know what the problem is. The problem is that for the last hundreds of thousands of years, carbon has had its fluxes up and down. And since the industrial age, carbon dioxide in the atmosphere has skyrocketed. And while we've always had fluxes, it's gone higher than ever before. And it's gone higher much, much faster. And this is really the root cause of all our problems. And then if your hospital is talking about this at all, or your practice or your town or your city, you hear these kinds of words that are shown at the bottom of the slide: net zero, decarbonizing, carbon neutral. And it's hard to even know what these things mean unless you become somewhat expert or facile with these terms. Net zero is what many hospitals aspire to become. It's a really high bar. It means that your hospital puts out as much carbon as it uses, and that means that it has to create some of its own energy or sink some of its own energy. More hospitals and healthcare systems try to become carbon neutral, which is there are nuances to these terms, but in general parlance, it's used to mean that you offset some of your carbon emissions by purchasing offsets or by other means. Because it's a really high bar to actually create your own energy or be net zero in that sense. And many articles that are in the Journal of Climate Change and Health and other journals, lay press, talk about decarbonizing. So let's talk a little bit about what some of that means. Next slide, please. There are some numbers that can help guide us, and this slide applies to things in your own life and to things that are happening around us. As you may know, the United States historically has been the biggest contributor to the total carbon dioxide increase in the atmosphere. But because it lasts thousands of years, depending on which part of the carbon cycle you're talking about, China now is the largest contributor to the carbon dioxide in the atmosphere per year, but we have been the historical large providers. And then many people say, but what can I do, in my own life? Because most of this comes from things that are out of my control. I looked into this to write a book that has just come out, and many people parse this different ways, but on average, you can kind of think about it, that about half of what happens to add carbon to the atmosphere happens from your individual choices. It's just that there's a whole lot of us, so it makes up a big part. But what you do as an individual in your private life, if you add that all together, about half of the overall problem comes from that, and about half comes from companies, industries, institutions, things like our healthcare sector. In terms of the magnitude, in the United States per capita, we are at the top of the food chain here, and we emit per person about 20 tons of carbon dioxide per year, while the world average is about 5 tons for persons per year. And to keep within the target of 1.5 degrees Celsius, we have to get down to about 2 tons per person per year, which is a really big shift. Next slide, please. And what's the implication of these 1.5 or 2 degrees of elevation? They're the things you already read about in the news that concern us all. That's why you're here probably at this meeting. It's more floods, fires, storms, droughts, and over certain levels, these things start to synergize and create more and more problems. And this interferes with our healthcare delivery in many parts of the world, including the United States, but around the world, even to a greater extent. We've all heard about increased heat stress in our urban and rural environments. This causes problems with agriculture and land use around the world. These increased elevation of temperature gives us problems with biodiversity and ecosystem consequences, with crop failure, ocean acidification, species migration that run into obstacles from altered landscapes that are important for our ecosystems to function properly. And then there are political and humanitarian crises. Some of the other speakers today are heavily involved in some of these things: food and water shortages, climate migration, increased conflicts, civil wars, battles for resources, food, water, and other essentials of life. So these are really important issues, and this is, of course, why we all care about it. Next slide, please. Now, what about the health sector? Some of you have heard these numbers. The health sector in the United States makes up about 20% of the United States gross domestic product. And in terms of the environmental impact, our sector adds about 10% of the greenhouse gases. The other commonly quoted figure is 8.5. There are only a few studies that have looked at this kind of in a global perspective, 5% in Canada. So we are really high, and that in part is because it's such a high part of our whole economic engine in the United States. And in addition to the greenhouse gases, because they come primarily from fossil fuel combustion, they also add particulate pollution, and these are major causes of global morbidity and mortality. In addition, there's enormous amounts of solid waste that may not be so big a part of the carbon footprint, but solid waste in itself is a real problem. In the United States, it's been estimated to be about 42 pounds per hospital patient per day. And of course, in our clinics and our outpatient settings, we also go through a lot of solid waste. This has gone up, of course, with the COVID pandemic and all the PPE that everybody uses. In addition, several professional organizations in various specialties have come out to say that the whole problem of climate change is the biggest public health challenge we face. I'm a pediatric provider, so the pediatric organizations have really stressed that the kids that we treat today are going to be the most affected. Next slide, please. Now, when you think about hospital systems or healthcare systems, the healthcare sector, which is very, very large economically and just footprint-wise in the United States, we always think about the things we can see, and we tend to think about all that plastic waste we throw out and how our machines work and the energy we consume. But it turns out that actually, when you break this down into what are called the scopes of economic activity for businesses, the biggest things are things we don't think about and see every day, which is what are called scope 3 or indirect carbon greenhouse gas contributions. And while some things come from energy we use on site and purchased energy, A lot of our footprint comes from scope 3, which is the stuff we use, the supply chain and the equipment and the things we purchase. It comes from things like transportation for your workforce to and from the hospital, transportation for your patients to get to the hospital or to the clinic. It comes from waste. It comes from things that we lease. And one thing we tend not to think about so much, a lot of it comes from investments, your pension investment in your institution, your portfolio in your investments for your endowments, for example. So people have estimated that scope 3 is 60 to 70% of our impact. And that feels to many of us even more removed from things we can control. So we'll talk about how you affect these things as we go forward. Next slide, please. Now, you may say, it's so much more harm that comes from the transportation sector or, the bad people that have coal mining or whatever. But even within healthcare, there have been some assessments of how much harm does this cause to health. So how much does the environmental downstream effects of the healthcare sector affect human health? And this was a paper, really a very interesting analysis by Matt Eckelman, Jody Sherman, Andrea McNeil, that looked at the Canadian healthcare system, because some of the data were easier to get in a nationalized health system than in the United States health system. And here's what they found. And if you look below, it's the highlighted part. On a life cycle basis, meaning they looked at everything from start to finish, Canada's healthcare system was responsible for 33 million tons of carbon dioxide equivalents, or about 5% of the national total, as well as many tons of other pollutants. And then when they looked at how much disability adjusted life years that caused, in decline, it was 23,000 dailies, disability adjusted life years. And that is about the same as all the kinds of dailies that have been calculated to arise from medical errors. And some of you have heard about all the attention that's been given to medical errors. We should reduce these because they cause disability. Well, the climate effects and health effects of our operations, from pharmaceuticals through transportation, through all the things that go into healthcare, are about an equivalent amount. So this is not an insignificant amount of something to pay attention to. Next slide, please. And one question that comes up when we talk about this to our hospital employees or people in the healthcare sector is, yeah, but we're about making patients better. In rehab, we're about improving quality of life, improving function, decreasing pain, all the things that you do that are so important in the rehabilitation world, and those of you in other areas of medicine. Don't we need to focus on that? But it turns out that oftentimes improving your carbon footprint, improving your environmental footprint actually aligns with your primary mission of providing healthcare and healthcare services to your patients. This is just one example. It turns out that when your hospital or hospital system becomes more sustainable, it actually can decrease your healthcare costs by significant amounts, so that decreased cost can go into better patient care or another nurse practitioner or therapist that can help patients even more. Next slide, please.
Tina, just so you know, we do have time limits here. I don't know how many slides you have.
Nope, we're almost done. Yep, thank you.
Okay.
We're getting through them pretty quick. This is just an example of an analysis that was done of a children's hospital that became more sustainable. Mortality and morbidity went down, staff turnover went down, air quality within the hospital facility went up. So there are co-benefits of doing some of this sustainable activity. Next slide, please. So the things can align. Some people have talked about climate change and adaptation and mitigation within the healthcare sector being a big opportunity because we can reduce waste. There's an expression, lean care is green care. Certain environmental and health effects align, like plant-based diets are healthier for you. Getting around by your own power is healthier for you than, driving everywhere, for example. Improved agricultural practices and land use, which are good for the environment, are also good for lower toxicity, fewer pesticides, fewer chemicals. Nature exposure and stress, which some of our other speakers will speak to, have co-benefits. And, being more environmentally careful can also decrease inequities. Adaptation for patients in healthcare system, no matter what we do, things are going to get worse before they get better. So we have to be adaptable and flexible, and this may help our healthcare delivery overall. Next slide, please. So there has been a call by the National Academy of Medicine and the Department of Health and Human Services to decarbonize the US healthcare sector, meaning no matter whether it's net zero or carbon neutral or just getting better, we really need to do this in the healthcare sector and play our own role. Next slide, please. And these are the things that they've specifically suggested: working with industry to reduce that scope 3 emission on our supply chain, encourage low carbon innovations, encourage hospitals to get better in their own energy use, encourage education and curricula on climate change that other speakers today will talk about, and develop healthcare sustainability metrics, which many people are working on as we speak. Next slide, please. And why should healthcare lead? It's because ultimately climate change is about health. We do have credibility in the healthcare sector, and we enjoy trust from the general public. We can help change culture and values to prioritize climate change and environmental improvement. We understand how science works, that this is an iterative process, and there's simply no time to waste. So I will turn it over to the next speaker to give you more details.
All right, we'll now move on to Dr. Caleb Dresser, and looking forward to his talk.
All righty. Good morning or good afternoon, depending on your time zone. I'm Dr. Caleb Dresser. I'm an emergency physician based at Beth Israel Deaconess Medical Center in Boston, and am assistant director of our fellowship, which trains physicians to take on leadership roles in addressing climate change and health. So I've done a lot of thinking about why we need to be thinking about this issue and what we need to be doing about it. I have no conflicts of interest relevant to this talk. And I want to share sort of an origin of why I'm concerned about this. And it boils down to, I keep seeing climate change impacts and the hand of climate change affecting the lives of my patients. This is one example of a patient I took care of during my emergency medicine residency, who really sort of exemplified for me how this can happen anywhere in any community. I'm in a relatively wealthy, well-resourced healthcare system in the United States, in the Northeast, and we're still seeing patients who are impacted by climate change. And as an emergency physician, my department is where a lot of people wind up, where the system or the housing or the intersection of their abilities and the environment create problems. So this was a patient in her 80s who lived independently, but had some physical mobility limitations, and whose air conditioner broke during a heat wave. And so she had done all the right things. She had ordered a new air conditioner, she got it delivered, but she did not have the physical ability to put it in the window and safely install it. And so the air conditioner sat boxed in her apartment for a couple of days. And ultimately she wound up brought into the emergency department with heat exhaustion and wound up hospitalized. And cases like this really sit with me because these are preventable illnesses. This is someone who was living an independent, good quality of life, and then suddenly required hospital care. And this is something that could have been addressed by a neighbor checking on her. It could have been addressed by somebody in the air conditioner business being willing to install that air conditioner for her, and there are liability issues there that can make it complicated. And so it really has gotten me thinking about how we need to be prioritizing health of people in the community or in the institutions where they live, rather than focusing purely on care when they get to the emergency department. I'm going to skip a couple of graphs in the interest of time. Suffice to say that climate change is causing a lot of issues for healthcare systems and is getting worse. And skip to this, which is sort of how I think about what we as healthcare providers, whether we are physicians seeing patients in a clinic, or somebody working in administration, or perhaps somebody who is a home health aide working with a patient who has limited mobility. Here are the things we can be thinking about that give us a roadmap for addressing this issue. And so this is the concept of climate readiness. And there is some really good documentation and in-depth reading you can do about this. There are government reports, the National Academies of Medicine has some good reports, but this is what we need to make our goal: a climate-ready system for people living with disability, for patients with complex medical conditions, because those are populations that are disproportionately at risk from the impacts of climate change. And so these are sort of the three areas, and they overlap, but these are the three areas where we can be effective. We can work on drawing down carbon emissions, as Dr. Duhaime was talking about in some detail. We can work on adaptation, and that might mean helping our hospitals deal with a hurricane. We saw what that can look like in Florida earlier this month. It might also mean something as simple as having a list of critical medications for a patient when they have to move out of their house and into a healthcare system because of a heat wave or because of some other climate-related issue. And we need to be doing both of these things through an equity lens. There are already great health inequities in this country and globally, and climate change is making those worse. And so any solution that addresses climate change has to address health inequity. Very briefly, we are going to skim through what climate change is doing to our health. Suffice to say, we've been burning a lot of fossil fuels, greenhouse gases are building up in the atmosphere, the earth is warming, and we are seeing a lot of environmental hazards being affected, things ranging from sea level rise to urban heat. And this is leading to impacts on our health, the health of people we care about, the healthcare system, and society at large. What does this look like in daily life? Well, I use the CDC's sort of social influencers or social determinants of health as a framework to think about this. Because rather than thinking about a bunch of complicated causal pathways, this gives us something we think about every day when we care for our patients. Do you live in an urban food desert? Do you have access to somewhere so you can safely exercise? These are questions we were trained to ask in medical school. I would argue we should add a couple more. Do you live in an urban heat island? Do you know what that is? Can we maybe talk about your neighborhood and whether it's really hot outside and whether you have access to air conditioning, either in your apartment or perhaps in the dwelling of a friend? And how is climate change going to affect some of the things you rely on for your care? And when this comes to patients living with disabilities, there can be medical assistive devices that require electricity or that might not work well when there's a few inches of water on the ground during a flood. And so we need to be really thoughtful about how these issues can interact and what we can do about them. I also want to bring in the concept of sort of the broader societal impacts of climate change and what those mean for our health and our healthcare institutions. These are three images from a hurricane, a wildfire, and an extreme rainfall event that show what can happen to the electrical grid, to a place that you might go for community and connection with other people, and to mass transit systems that a lot of people rely on. This affects whether there's a hospital open with the lights on for you to go to. It affects whether you have people who are checking on you, whether you have emotional support for navigating some of the challenges that come with healthcare. And it affects whether you can get to your clinic appointments, to your dialysis center. And so impacts on infrastructure and broader societal functioning, I think, are something well within our purview as either healthcare providers or people living with disabilities to advocate for as essential to our health and the health of our patients. As Dr. Duhaime was alluding to, there's a lot we need to do within the healthcare system. We can be powerful voices, whether as providers or as patients, about why our system needs to stop being part of the problem. And I will leave it there on that particular subject because others have more to say. And just share a couple of thoughts on how we might step into these roles. What are those specific actions that Dr. Alexander was referencing that you might take? How do you actually translate this into action in your life? And I would break these into clinical solutions, things you can do caring for patients, community solutions, so things that you can do as a member of your community, whether you are a patient or a provider or something else. You have a lot of voice among the people who care about you and the place that you live. Institutional solutions, and these might be things like decarbonizing a healthcare system or advocating for a disaster response plan that reflects future flooding risk rather than past flooding risk. And finally, policy solutions, because there does need to be incentivization and in some cases, I think regulation that moves the healthcare industry towards sustainability and resilience and keeps people safe. How do we get people working on these things? Well, part of the story is education. I think today is an example of how we might sort of start the conversation about some of these topics. Then the second piece is advocacy. How do you make your voice heard in a meaningful way? And there are tools in both education and advocacy that you can learn to increase your effectiveness. We are close to times where I'll briefly breeze through a couple of examples of what this can look like in practice. Example number one, heat waves are getting worse with climate change, and we know that they disproportionately affect people living with isolation, people living with limited mobility, people living without air conditioning, and a variety of other social factors and medical factors. And so I have been working with local organizations to deliver fairly targeted, straightforward messaging on how to recognize heat-related illness and how to prevent heat-related illness and when you need to go to the emergency department. And not only presenting this to community organizations and patients, but also presenting it to home health aides and VNA nurses who are right there with the patients who are most at risk. And so getting this information into the hands of people who need it is key. I'm going to skip the second example. We can talk more about sort of big data and mobility in disasters, and I will pause there.
Thank you so much, Caleb, for that great talk. And we're now going to transition over to Dr. Lewandowski.
Okay, great. Hi, everyone. My name is Eric Lewandowski. I'm a child and adolescent clinical psychologist affiliated with NYU Medical Center in the Department of Child and Adolescent Psychology. And actually part of my climate origin story is relevant to that introduction, is that I have an affiliation with the medical center, still involved in clinical teaching and education, but I've moved my practice outside of the medical center. And one of the main reasons for doing that was to have more time to engage in climate activities. And so the origin of this story is my sort of climate turn, if you want to call it that, was in 2018 with the release of the 2018 IPCC report, the 1.5 degrees report. And at the time, I remember being just hopping mad and panicked and unclear what to do with those emotions. And I didn't see necessarily in my immediate surroundings that reflected by others, although it certainly was, just not that I could see with my eyes in front of me. And sort of life took over again. And until 2019, the very same input, very same revelations, no longer revelations, but in the 2019 report. And at that point, I basically was saying to myself, well, this is clearly going down. And however it's going down with me in the game, no longer on the sidelines. And so that started a sequence of personal and professional developments that has led me to this particular moment. And obviously with that timeline, I'm new to this. And I think that's sort of one of the things which I'm glad to report in this talk. And some of the things I'm actually still surprised that I'm on a panel like this, as new as I am to the effort. So I'm hoping that that's an example of sorts. So I'm talking about mental health professionals. I'm the only mental health professional on this panel. And my engagement with this field has not been, it's not necessarily confined to my role as a mental health professional. In fact, it's not really part of my clinical role. It's how have I used my clinical training, my research training to engage with this problem, which is of such personal significance and also obviously is rooted in my professional background. So just highlighting this will be easy to grasp for everybody. So some of the events, the weather events that we're all well acquainted with by now, and we think about the impact of these on, on our homes, our families, our livelihoods, our lives, it's not much of a stretch to understand how these will impact mental health. And there's a well-established literature about the direct impact of weather events. And this is sort of the disaster mental health literature. Mental health impacts of disasters and the aftermath of disasters, an established literature looking at the impacts of heat on aggressive behavior, homicide, violent crime, domestic violence, even suicide, air pollution and behavior problems in children, cognitive problems in the elderly, and an emerging literature on the impacts of chronic climate events, for example, drought or rising sea levels, which is lagging behind the rest. And I won't get into too much of this, but I will refer you to these three excellent review papers for sort of the state of that right now. And so these are where I'm talking about here are direct impacts and something which is sort of really rising in the public eye. Actually, Grist magazine called Climate Anxiety, the Pop Culture Phenomenon of 2019. We're talking about here about the vicarious emotional impacts of our awareness of the climate crisis, the escalating impacts of the climate crisis. So this is out of direct contact with a specific climate event. And there's really no established definition. And I'm talking about this because this is actually one of the points of interface that I've had with climate action, climate activities, is in climate anxiety. So there's no established definition or prevalence data. It's actually, because it's hard to define, it's hard to measure how much of there is. But it's really, characterized by not just anxiety, that's probably too narrow a term, but bouts of worry, grief, despair, panic, sadness, hopelessness, and anger. And a reasonable question is this a mental illness? So here I'm a mental health professional, and I've encountered this in my office, certainly not as a presenting problem, but as a background state in young people in particular. And I would say emphatically that it is not. Climate change is a real threat, and it's rational to be worried. So in this case, anxiety is an adaptive emotion, which is signaling danger. But of course, so actually, I think a reasonable comparison condition is how we think about grief. So nobody would say, except in some certain, small minority of cases, that grief reflects a mental health problem. But it is certainly a consuming and very painful, disruptive experience. And there's some finer points. Actually, one of the things I'm involved in now on the academic front is trying to actually adapt sort of scientific understandings of grief to climate distress, climate emotions. And however, in severe forms, people who are distressed about climate change, have emotional distress, may require or may benefit from clinical support. And I say my clinical practice doesn't focus heavily on that, although I do have colleagues who operate much more in that space. So one of the things that I had very rapidly had the good fortune to participate in after I really started to take early steps in trying to engage in this work was to be a part of the first study of its kind, of global study of climate anxiety in young people. And this was published in Lancet Planetary Health about a year ago. And we looked at, this was a survey done across 10 countries, 10,000 young people, 1,000 per country. You can see the countries listed here. And we asked about their feelings about climate change, their thoughts about climate change, and their thoughts about government response. I'm going to share with you some of the findings from this. So this was our total sample, 10,000. 45% of the respondents in the survey reported that their worries about climate change were having impact on their ability to function, daily function, eating, sleeping, concentrating. And then this was a report of worry about climate change. So this is 84% were at least moderately worried, and almost 60% were very worried or more. And so here are the countries broken down. And something that was really notable here is that very striking is that the low and middle income countries, in fact, there was no actual low income country as defined by the World Bank, but these are middle income countries and low middle income countries, had very strikingly greater proportions of people who were reporting functional impact, and also a significantly greater proportion of people who were reporting greater worry, very or moderate or extremely worried. Also notable, the United States was the lowest across the board. And yeah, so that's the developed country or the high income country functioning. And so here's some of the things that we found. So you can see large majorities of people, this is in the US now. So this is the lowest distress reported across all the countries. Large majorities of young people reporting that they're anxious, sad, and afraid. And much smaller numbers, more or less a quarter, 1 in 4, reporting that they're indifferent or optimistic. When it comes to thoughts about climate change, you can see large proportions reporting that people have failed to take care of the planet and that the future is frightening. One thing I want to point out here, this is a relatively, I don't know if you can see my cursor, but down to the right of the page, 36% reporting that they are hesitant to have children. Now that's a smaller percent than the 68 and 75, but that's a large percentage in our view of people who are contemplating these fundamental life decisions that in previous generations might not have been contemplated in the same way. And I'll also say that this is not an indication of people who will opt not to have children, just the reflection of the thought that the fact that this is on people's minds, this question, that this is a decision which is now a question. So I've talked about the level of distress here, and I'm also mindful of time. And I want to talk about coping. And as we think about with grief, we typically say, well, somebody who appears to be coping well likely is coping well. And I would suggest the same thing is true with climate emotions. However, that doesn't mean that you can't discern patterns in coping as we do in grief. And there's a paper, a 2012 paper by a Swedish psychologist, Maria Ojala. I believe she's in Sweden. I believe she's Swedish as well. Where she talked about, she studied the coping patterns in 12-year-olds. This is a school-focused study, and she was able to identify different coping strategies and how those strategies relate to the emotional experience of climate change, or how those children were faring emotionally. And she highlights differences: emotion-focused coping, meaning the coping approach is designed to reduce distress, the emotional distress, meaning how do I feel better? Problem-focused coping, meaning how do I solve this problem? And that's the path that I choose to try to cope with my distress. And then a third one, meaning-focused coping, which reflects kind of a taking on your actions, I suppose, redefining your identity in a sense with respect to climate change. So making it sort of the purpose of your person, your existential purpose on Earth here is sort of engage with climate change, with the climate crisis. And she found that people who opted for this emotion-focused coping did not actually have any relief of their distress about climate change, nor were they particularly engaged in climate activities. People who had the problem-focused approach actually had a high degree of engagement, but not much relief in distress. And people who sort of had this meaning-focused approach actually did have improved feelings of well-being, reduced distress, and high engagement. And so this sort of seemed to be the most sustainable approach, bearing in mind what I said before, whatever's working for you is working, but some of the ideas here can be taken about, ideal ways or optimal ways to perhaps engage. And I should say, engaging in this way, we don't have the expectation that it will eliminate negative feelings, but rather buffer, help one to bear. I'm just in the interest of time, I'm going to skip this actually. So this is just sort of this is a functional analytic framework, something that underlies a lot of our clinical work with depression and anxiety, in particular in adolescents, but also across the age range, where I'm just sort of reflecting that very same thing, those distinctions between meaning-focused, emotion-focused, and problem-focused. Now, the one thing I want to highlight here is, so in this formulation, I'm suggesting that engaging in the ways we just talked about is actually something that can have benefit emotionally. And then we talk about barriers to that engagement. And one that I encountered, and I'm sure is familiar to many of us, is this: well, I'm just one person, certainly to my clinical role. I'm just one person, what can I do? And we need sort of a credible answer to that to figure out where to go, what to do. And I find this picture is really compelling for so many reasons as an answer to that. And obviously we have a very prominent person, just one person, although cynics or skeptics might debate that. But I'm much more focused on all the individuals in the audience. And this picture was taken in Montreal in 2019 in the climate marches that fall. And it's an urban population of 1.5 million. There are 500,000 people in that city who marched. So is it really just one person? And I thought about, in this picture, what did everybody do the next day? And what has every one of these people, these 500,000 people, done in every day since? And so the thing is that's difficult when we come to this is how hard it is to understand the aggregate, the whole that we are a part of. And we really need to act with that in mind. And so in that aggregate, this is a huge, and it's much bigger than this, obviously, a voting block, a purchasing block. But even more than that, we are an engine of norm changing with our examples. And if you think, Bill McKibben recently in his climate newsletter, The Crucial Years, said, why do we protest? He says, it's to change the zeitgeist. And I would say this is a reflection of our power, of that in action, and also sort of a reflection of our ability to do that through all of our actions in multiple facets of our life. Just to reflect, again, and I'm mindful of the time. This was Ed Markey's response to Jane Fonda in an interview when she asked, what can we do? She says, well, we need an army. And then in the words of my colleague, Harriet Sugarman, who wrote a book called How to Talk to Your Kids About Climate Change, with respect to activism and the social challenge we face in life, looking in the mirror, she said to herself, you know, who will do this work? And she said, look no further. The army is you. And that's something I've really taken to heart. And so really, what does it?
Dr. Lewandowski, we're going to have to save time for, okay, we have to save time for Dr. Lowe.
Yeah. So the last sort of thought here is, what does it mean to be a part of this army? And I think Caleb was referring to it momentarily, just a moment ago. It really means, I think, to accept and welcome the challenge of climate change and to draw it to the center of our identity, and then to look for every expression of that identity we can in every facet of our lives. And, you know, there's some sort of general ideas here, which I'll skip, but the one I want to highlight the most is to make this sort of commonplace that we talk about it with our colleagues, with our families, in our communities, and to really look for a climate community, climate buddies. And from that soup, really, we have a much better vantage point to understand what our particular steps will be in our particular sphere of influence. You'll have these in the PDF. I won't take the time to read it, but maybe you can look at that in the PDF that will be circulated. Thank you.
Thank you so much, Dr. Lewandowski. We have a number of questions. I'm going to turn this already over to Dr. Lowe so she can sum up from a rehab standpoint.
All right, great. Let me just share my screen here. Let's see if we can. All right, can everyone see my screen?
Looks good.
All right, excellent. So my name is Anita Lowe Taylor. I am now practicing full-time rehab medicine in Helena, Montana, but I'm a recent graduate in physical medicine and rehab from Stanford. I also serve on the board of the Montana Health Professionals for a Healthy Climate and serve as a representative to the Association of Academic Physiatrists from the Steering Committee for the Medical Society Consortium on Climate and Health. So I'm going to talk a lot about kind of practical ways where we as individuals can get involved. That's one answer to that question of, I'm just one individual, what can I do? I'm hoping to offer a few kind of concrete solutions for that. Part of that is by explaining the quality improvement process. And because that's how I initially got my foot in the door on this issue within my institution. I'll also talk about PM&R waste, so rehab waste, what we know, what we don't know, which is a lot, and a few solutions for us. So getting involved. It's an overwhelming issue. You're just one person. I found myself kind of hesitant to even get started on this initially because I just didn't know where to begin. But you have to start somewhere. And I would argue that starting as a resident or a student, a nursing student, therapy student is an excellent time to get started. But partially because most residents, and I think this might be true of other training programs, are required to complete a quality improvement project. And you can use climate change and health as your project there. You also have institutional resources available. You've got a bunch of bright minds around you. Perhaps there's already existing teams and perhaps even some funding. So I was overwhelmed getting involved. So I created this kind of silly roadmap about how you as an individual can go about getting involved. And I would say you can start by making connections, and that can take the form of joining organizations, both local or national climate change and health organizations, and also joining your specialty organizations. For example, I'm a part of the Association of Academic Physiatrists, and that allows you to translate your knowledge on climate change and health into your specialty. You can also explore your own network of people, so your friends, your family, your colleagues, your coworkers, and just ask them if they understand the problem or if they're interested. I was surprised at how many people were interested in this issue when I went about asking. And then you can start taking direct action as well through QI projects, which I'll go into in detail today, or education. You can present at your didactics, your grand rounds, and if you have the cloud national meetings as well. And then research, there's tons that needs to be done, especially in rehab medicine. So I think QI projects are a good lens to take when you're viewing about how can I enact change in my institution, my local setting. And so there are certain concrete steps that you take in a QI project, starting from team formation, background, developing a problem statement, doing a root cause analysis, and then enacting some changes, which I'll go through step by step here. So team formation, rehab medicine is especially suited for team formation because we already work in teams. So we already work with our therapists, our nurses, our social workers, our clinic managers. And so I'd say that we're one of the best specialties as far as already having a built-in team that you meet with regularly, especially on the inpatient rehab side. So background, I think we've heard a lot about this already today, but healthcare is extremely wasteful. Some studies say the second most wasteful industry in the US. And we in the US are especially wasteful. So the US produces 17 times as much waste per bed per day compared to like a low-income country like Nepal, for example. So if we can enact change here, we have a disproportionate impact on this issue. Now, COVID increased waste. I think all of us are intuitively aware of that, but some studies say up to 10 times more waste was produced during COVID. And one study said that PPE increased carbon emissions by 1% in the UK, which is huge. And medical waste is going to get worse. So the population's growing, we have an increased burden of chronic disease. All of this equates to increased healthcare demand, which of course generates more waste. So we need to start tackling this issue now. So waste in medicine is clearly a huge issue, but what about rehab medicine? So when we were looking into this as part of my QI project, we found that there's very little literature on this. And so we needed, and we still need as a specialty, to establish a baseline. So one of the ways to go about doing that is a waste audit. It's a very practical, tangible way to get involved. A waste audit is a systematic way of evaluating key waste drivers at your institution. Now, a lot of studies have been, or some studies have been published in the inpatient and the OR setting, but there have been very few in the outpatient setting. And to my knowledge, only one, which was the one I worked on in rehab outpatient setting. There we go. So as part of our project, you develop a goal. So you want to kind of create a tangible goal for what your project is focusing on. So our goal was to reduce per patient clinical and administrative waste at Stanford PM&R clinics by 30% by May of 2021, and to create a template for implementing these waste reduction strategies that can be adopted by other clinics. So you want your goal to be very specific and in time limited like that. So then you go about doing a root cause analysis. I won't go into detail on this very complicated fishbone diagram, but I do think it's a good framework for conceptualizing the complexity of the problem and helping to select a target area. So we found that lack of baseline data was a big issue, education gap, clinic flow, you're busy, you're rushed, how are you going to worry about waste, cost, and then some fixed limitations all contributed to the problem that few, if any, policies in our institution had been created to minimize clinic waste. This is another complicated chart, but it's again helpful for organizing how you're going to go about your counter interventions, your countermeasures. And it essentially takes the key drivers of the problem and juxtaposes them against interventions that you've planned to address them. So we wound up focusing on conducting a waste audit, and then again, creating a template for easy replication in other clinics. So our waste audit down and dirty, the setting was an academic PM&R outpatient sports and spine clinic. Our goal again was to identify key waste generators that we could target for interventions. And the process was we collected waste from 31 randomly selected encounters over 6 months. Now these ranged from outpatient new clinic visits, follow-up visits, EMGs, in-clinic procedures, and outpatient surgical center procedures. And we weighed all waste. So the paperwork, the gloves, the exam room table, you name it, we collected. So these are our results. Not surprisingly, procedural waste was the most significant driver of our waste. But what was surprising was some of the nuances involved in there. And that's where I think the magic of a waste audit happens. So for example, we found that a procedure performed in the clinic created 6 times less waste, that's here, compared to the same procedure performed in an outpatient surgical center. We also found that different techniques were utilized by different practitioners, which led to very vastly different waste patterns. So Clinicians who selected individual sterile components for a procedure produced far less, so half the waste of those who used a prepackaged waste kit or prepackaged procedure kit, as you see here. And so we estimated that over a ton of waste could be saved from the landfill annually, just if clinicians changed that one practice. And this is especially important because a lot of recycling companies are quite hesitant to accept waste or to recycle waste that appears clinical in nature. And so we really had to focus on the upstream waste reduction because there wasn't really any options for recycling. Now, of non-clinical waste, I should note that you can recycle. Recycling costs way less than solid waste disposal. At our institution, it's costing 7 times less. So this is also a good area for economic savings. Now, we also did a telehealth component of this, which was a huge issue during the pandemic. So we collected transportation method and travel data from our patients. And then we calculated that the 5,000 video visits conducted at our institution in 2020 compared to the prior year, 2019, saved an estimated 270,000 driving miles, which equates to 11,000 plus gallons of gasoline. And that's actually enough to drive around the entire earth 11 times. That's one clinic at one place. So televisits have the potential to have a huge impact. Now, PM&R Waste future directions. We have so much room to go. So there's very little, if any, data on waste produced by rehab facilities, SNFs, LTACs, et cetera. But you can imagine that they do produce a lot of waste. Isolation gowns, when you have a bunch of different team members, because you've got therapists and social workers and doctors walking in and out of rooms all day, every day. Wound care supplies, because wounds are a big issue in our population. Catheters, all these items are no doubt producing waste, and we need to quantify that. Also DME. So a lot of our patients have mobility challenges and they use power wheelchairs, they use Hoyer lifts. What happens to those once they break down? Now, some are recycled and reused and refurbished, but a lot wind up in the landfill. And I think we could do a better job of recycling those. All right, so I realize that we're short on time here, so I think I'll probably skip these slides, but there's huge potential for reducing our waste. Again, I would argue that one action that individuals can take is do a waste audit at your institution, find your waste generators and find ways to reduce those. And then recycling. There's a huge potential if we can get it in clinics. Again, there's some limitations there. There's some studies that estimate that 60% of OR waste or ICU waste could be recycled. So that is a big target for us. So the whole statement, reduce, reuse, recycle, we have a lot of room for growth in that. All right, being mindful of time, I will stop there and end my screen and we can move on to the discussion.
Thank you so much, Anita. And I'm going to start working on the questions here. We've got some nice questions here. And actually, I think what I'm going to do first is screen share myself because I tend not to share the possibilities to get involved that are available for people. So the first question we have is, how can we take action to be part of global community initiatives? And I'm going to share with you the work that Sustain Our Abilities is doing. And also a little bit of my story. I was heavily involved in this until my children grew up. And then I left the full-time practice of rehab medicine to get involved in climate change and disability. Largely because I tried to talk about it and nobody wanted to listen for a long time. And one of the things that you can do if you want to take action is get involved with Sustain Our Abilities. We really work on the issue of climate change and disability. And we have had presentations that people have done around the world. This year, we've had a number of presentations in Greece, a number of presentations in Nigeria. We're having a presentation in South America dedicated to Day for Tomorrow. And this course is about Day for Tomorrow. And the concept is we want to get people together in community to work together to conquer climate change. And these are some of the events that are still going on. But one of the things I want you to see here is the issue of taking action. Donating is one thing, but we have pledges. And the idea of the pledge is we've got a form here, and I apologize for that. Well, we've got a form that you can actually just check on to see what your pledge will be and what action you're going to do. And an opportunity to share your pledge, to get others to be involved. So that's just one way people can get involved. And I would like to say, Caleb, maybe you want to answer that question again. I'm going to stop screen sharing here, but I think that I want to share this question with other people because there's many opportunities you can have.
Yeah, my overall sense is that this is scary, it's real, it's happening, and we need to get together and work on it as a team. I think this can feel emotionally overwhelming if you feel like you're tackling this on your own because it is a big, complicated problem. And so what I advise people to do is think about your positionality a little bit within this issue. What is your role in society or your role in healthcare? And where are you physically located geographically? What communities are around you that may be impacted? And what hazards from climate change are you dealing with? And so for my example in Boston, climate change is really overwhelming when you look globally. If you look purely at Boston, this becomes a conversation about urban heat and some of the health inequities that result from that, extreme rainfall events, occasional hurricanes, and sea level rise. And so that becomes a much more focused conversation around specific hazards and specific communities that are being impacted. So step one, I think, is narrow it down to things that you're going to interact with and can speak to. And then step two is find your team. And as Mark Lee was alluding to, there are a lot of really good organizations working in this space. I would generally suggest that finding any team is better than finding no team. And that probably a good starting point is to find one team that you can work well with. And that might be your hospital sustainability committee or green team. And this could be entirely institutionally focused within your institution. That might be linking up with the Medical Society Consortium on Climate and Health and working on sort of advocacy and policy work. Which brings me to the final piece, which is play to your strengths. Some of us really like communicating. Some people like being on camera. Some people really don't. And some people are really good at managing email lists and organizing events and making stuff happen behind the scenes. Whatever your skill set is, play to that strength. And I think this will be a more sustainable thing to work on. And you'll find that you have a valuable role as a part of a larger team with various skills.
Thanks, Caleb. Eric, any other comments on that? You're muted.
Find myself just kind of nodding along with Caleb. I agree with everything he said, and put a point of emphasis on that. Find your role, whatever your natural inclination is, and it's a ongoing process of trying to figure out what that is, an evolving process. And what's true at the outset may not be true several months or years down the line. Yeah.
And you may not be a starter. You may be someone that's more of an amplifier. So if other people are taking the actions, sometimes the best thing you can do is amplify the actions they are taking, is one thing I would say. And I also do want to say that this has been a very US-centric panel, and our other panels have been much more international. I think a key here is that rehab hospitals and rehab professionals everywhere need to be part of the solution. And we need to work with people living with disabilities, with the lived experience of disabilities. Sometimes there's, questions about the medical model versus the social models of disability. And so I think the key here is we really need to be part of the team and work to be part of the solution wherever we are. And not, some people may think local, some people may think international. Really, this is a problem that doesn't matter what you're doing, as long as you're doing something positive, everything is going to help. We're going to move on now to the next question, which is going to be research ideas in climate change for rehabilitation still unclear. Can you give ideas? We have talked about this. Nita, I'm going to let you answer this first, and then maybe Tina and myself will chime in.
Sure. I think, rehab medicine is really just starting out with this. We're behind where some specialties are, like pediatrics, even psychiatry, I think is really more advanced than we are. So there's endless options. For me, I listed a few during my presentation. We don't even really know our contribution to the waste side of the problem here. And so we need to quantify that in rehab units. We need to quantify that more broadly in outpatient clinics. So I would say that's a huge one. How this affects people with disabilities. There is some research, but it's really not nuanced enough yet. So not all disabilities are the same. The person with a spinal cord injury is very different than the person with a traumatic brain injury, is very different than the amputee, and how susceptible they are to, say, heat or smoke. We're starting that, but there's so much room to grow there. So I'd say, the list of possibilities is huge.
Tina, did you want to add anything to that, or should I go take that?
Well, I think there was a question in the chat about basic researchers, like not necessarily clinical researchers, but people who are doing research in a lab. And there are programs that are available for lab researchers to try to make their research more sustainable. So I'm not trying to sell any products, but Practice Green Health has a little bit about that. There's an organization called My Green Lab that that's all they do. They're a nonprofit. They come into labs. All of these things may require some investment of certainly time, but sometimes money. However, when you get greener, whether it's on the clinical side or the research side, there can be considerable cost savings. So it balances out. The trick is getting the people who have the purse strings to believe that this is an important investment. And as others have said, Caleb and Eric and others, find your team. And once you find your team, you can have some collective influence to help your institution go in that direction. But there are things available for that now.
I'm going to continue to add to the issue of rehab because I do talk about that a lot. And in terms of research and rehabilitation, we've been working, Sustain Our Abilities has developed a database, and what we want to do is actually take what Anita just mentioned and really drill down with it. People with disabilities are impacted differently by climate change. What Anita did not mention is people living with mental or cognitive disabilities, people living with autism, people that are blind, people that are hearing impaired, and different groups of people have different needs. There are also different needs based on what country people live in and what region people live in. So for an example, one of the initiatives we're working on piloting, and I would definitely seek partners, is providing adaptive devices for people living with spinal cord injuries. They can't control their temperatures. So having cooling vests for people with spinal cord injuries could be something important to do. So those are some aspects of research. And then there's another issue. The question becomes, what is, we talk about waste and we talk about waste audits, but the other question is, what about the devices people are using? What about the supplies? What about the origin of the supply chain and all the plastics we put into catheters or needles that people are using for diabetes? So research can really run the gamut of development to utilization to impact, and that's what I would kind of add to that. Anyone else? All right,
I might
question.
share one slide, if I could, that I glossed over during the talk, just to sort of highlight another dimension of research that we should probably be thinking about. So This is from, again, my perspective in emergency medicine, where we are seeing sort of impacts from acute events. So there's two maps here. On the left is a federal government database of people with electricity dependent medical equipment. And that might range from like a home nebulizer up to like an electric bed or an electric scooter or wheelchair. And so this is a population that is particularly highly at risk during a natural disaster. And then on the right is some mobility data we have from Hurricane Ian in Florida a couple of weeks ago, showing in red areas where people are leaving and in blue areas where people are congregating. And so I think there is a big question of continuity of medical care, access to care, and access to disability-related services during climate-related natural disasters. And we need to be engaging on this. We need our voices heard on this issue, because the solution cannot be go to the ER where we don't have medical records on you and may not be staffed or trained to really do a good job. It would be really good if we're working with the Red Cross, working with other organizations to provide community-based care, even for populations that have to move in the face of wildfires or hurricanes. And this is research that is in its early stages, but we are really interested in partnering around how do we keep things safe for this population. So that's just sort of another like public health disaster medicine lens on that same issue for this population.
So a quick comment in the chat here is I worked in New Orleans last year during the hurricanes, and I can think of 3 patients that ended up admitted to rehab really as a home. Because they ended up in the hospital due to lack of preparation, showed up at the ER, and then the hospital had people sitting here, and then what did the hospital want to do? Find them a place to go. And that's not proper use of hospitals. It's not proper use of rehab. So some preventative issues are also another thing. We had a person, Gretchen Dillon spoke last week about being in the hurricanes in Puerto Rico. And one of her recommendations was just having small portable solar panels, just the little ones you might have in your pocket, the little tiny ones, just because those can happen, those can help you power little devices. We have another question here that I'd like to go to, and that is, to what extent, and maybe Eric, you can comment on this, to what extent have people looked specifically at the exposure and susceptibility factors with people with serious mental illness and or substance use disorders for disproportionate heat-related hospitalizations and deaths? And it might be Eric, it might be Caleb.
Yeah, actually, I don't know that I have a good answer to that. And I think that the fact that I don't have an answer to that reflects the fact that research in this area is very, very young. You know, the sort of initial planks of an evidence base are being laid now and sort of synthesizing what has gone before, but I'm not aware of specifically anything about that. And so I'm afraid I can't comment much about that. Caleb, I don't know if you have any thoughts.
Which comment are you referring to?
The issue of substance use disorders and serious mental illness.
Yeah, so I certainly care for this population in the emergency department. I think there is a fair amount of evidence that people living with various psychiatric conditions, in particular patients on certain categories of drugs, are at higher risk during heat waves. Figuring out why is complicated. There is probably some neurobiology that I will defer to Dr. Duhaime on, but there's also probably some social mediation, right? This also overlaps with an unhoused population or a population that may not have access to air conditioning, may be living in shelters, may have housing instability. And so I think my approach as an emergency physician for this population is that step one, I try to identify and stabilize the emergent condition, if it's heat stroke or heat exhaustion or whatever it is. And then if they are healthy enough and better enough that they can leave the emergency department, I generally try to do a check-in and figure out where they're going and what the plan is. Because I don't think discharging people back into a situation that wasn't going well is safe or ethical or helpful. And so in the same way that we, for an elder who's having recurrent falls at home, we'll get like a PT evaluation and maybe talk with a case manager about how to create a safer home environment. For patients who are coming in with heat-related illness that's overlapping with other issues, I may keep them in the ER where it's air conditioned and we have meals, and get a social worker in to meet with them and sort of talk about safe options, even if it's short term during the couple of days of remaining really hot weather during a heat wave.
Any other comments on that one? One comment I would have is that along the same lines, something I learned through the journal is the issue of sexual abuse. Sexual abuse increases during disasters, and that has not really been studied too. So there become so many intersecting factors, and that's why climate change is called a wicked problem. The other question I would ask as we think forward is, will rates of substance abuse increase because of climate change? As a mechanism of coping, people tend to use substances. And one could hypothesize then with climate anxiety, one of the responses for climate anxiety could be using substances. So I think we've got to, consider all those things going forward. All right, one more question. Any advice on how to engage the topic of healthcare's contribution to climate change with colleagues in a manner that doesn't result in defensiveness? In my experience, certain healthcare professionals respond with, "But I'm helping people." And that comes from David McMillan. And I would agree totally with that. One of the issues that we don't talk about here is how, for instance, in the United States, there are pockets, places like New York, places like San Francisco, places like Boston, where people pretty much accept the problem of climate change as being a problem. But in places in the South in the US, climate change is really denied. So how do we address colleagues and get them involved? Eric and Tina, you want to go to this one?
Sure, I can. I have a couple thoughts. One is, this is just through trial and error. In my experience, my first sort of effort to do something with colleagues, I suppose I found that my example, trying to lead by example, was something that I was able to fall back on, and I understood that I didn't have powers of persuasion, say, to talk this way or that. It certainly wasn't something I was professionally, more developed in or anything like this. So, what buy-in I found I've gotten from colleagues is through doing what I'm going to do, and it sort of draws attention, draws interest, draws sort of joining. That's one aspect. The other thing that comes to mind is what I've heard Al Gore talk about this, about, what do you do with climate deniers? Let's say, how do you talk to those people? And I hope I'm not misremembering what I heard him say was, we've stopped trying to persuade those people, and in fact, we're trying to engage those people who are sympathetic audiences and help sort of leverage that. It's almost like, you use a political analogy, a get out the base strategy rather than a swing voter strategy. So there's just some thoughts.
Tina, any comments?
Yeah, absolutely. This is the problem, isn't it? Trying to get people to come along when they think that, their mission is to help patients and that this is a distraction from their mission. And what worked for us was aligning those missions. So you can save money, you can be more efficient, utility costs are high. So, for us, what worked was having people have said this over and over, but it's social networks. It's other clinicians that are like-minded, as Eric said, and others have said. So it's having sort of a team, and then appealing to your institution and its leadership, oftentimes by economic gain. And, our institution now touts this as having been for sustainability, but really a lot of the decisions that actually were pro-environmental were done for economic reasons, because it was cheaper, regulations were coming down, building codes were changing, efficiencies were necessary. So a lot of times you can appeal to people to make pro-environmental change without the environment at all. It's for their other self-interested reasons. And also in this whole climate and health thing, it's because many pro-environmental behaviors actually align with better health for our patients and the communities we serve. So it's appealing to them on an intellectual basis, on a self-interest basis, and then for those who are sympathetic on a community and kind of big picture future of the planet basis.
I would also add 2 points to that question. And that would be that we need to look at our neighborhoods. We need to look at where we are. A lot of times people interested in climate change are not people that get out there locally. You may have colleagues at your institution that are out there nationally, but not locally. And I think sometimes we need to find those people. Sometimes they also may not be in the actual clinical space of the institutions. For instance, now there are some climate and health master's programs that go on in different places. And you may need to reach out to those students. The other thing is that there are some organizations around the country that are so big that they have maybe 5 or 6 centers on climate change, and people in the same institution are not networked. So I think there's all kinds of things you might need to do. But the one thing I would say is, someone once called me, and probably more than one person has called me this, relentless. And I think we need to be relentless. We have to be prepared for failure. I can say for every 10 things I do, maybe one of them sticks. And I think that we need to be prepared in terms of climate change for that, because it's not an easy mountain to climb. You've got to be prepared for you've got to be prepared for what you do to not work, I think, and just continue to move forward. And I'm going to segue to our last question here, because we've got 5 minutes left, and I think this is an important discussion. And this is more of an international level, but the question is, how can I, as a primary health provider, become more actively involved in climate change in my country, as it is not currently an area of priority? And I think, that might be something that countries that are, in the lowest center of economic development might say, but it also might be something that's said in big countries too. It really depends on your locale in the country. So I'm going to turn this one to Caleb, since he has, the policy view and
Sure, thank you. This is a really good question. If we were able to see you on camera, I would ask you what your ideas are, and I would be very interested to hear them. My general reaction to this is that there are a couple of very practical things you can do. Item 1, look at where you are, look at what the hazards are, and figure out how this issue is specifically relevant to the patients you care for and the community you serve. And I would suspect that you occupy a respected role in that community, and that if you are approaching this issue in a measured, scientifically based manner, you can probably make a case for why this needs to be a higher priority. Zooming out a little bit, if you're thinking at a more national level, wherever you are, we should think about how to make this a higher priority item. And inevitably, there are going to be a number of other really important issues that also deserve to be high priority items. But figuring out how climate change is specifically affecting people where you are, what's expected to happen in the years to come, and what the concrete policy actions are that you would like to see is the way to move forward. And that last piece is really important, because just saying, hey, this is a problem is a good start, but it does not lead to impact. Right? Impact is at the end of the day going to mean changing something about what we do. And that might be how we treat patients, how we counsel patients when we discharge them from an emergency department, in my case. Or it might mean advocating for legislative solutions that devote dollars and cents, or whatever unit of currency you work with, to keeping people safe and preventing health impacts. I think that's really where the long-term focus needs to be. And we can prevent health impacts either through good adaptation policy or by drawing down carbon emissions.
Eric, any comments on that?
No, I mean, as always, Caleb, I'm nodding along with Caleb. You know, I think Caleb, what I heard, and I suppose what I'd reflect as well, is essentially to try to think locally, do what you're going to do, make the case, and basically to try to describe the challenge and some solutions, and walk as far as you can while making that case as well. So it's, I mean, Caleb, if I'm summarizing that right, I don't know specifically where you're coming from to this person who asked the question, but you know, it's not a foreign experience to me to find ideas not have purchased. Markley, echoing your thought as well. Certainly, I do understand it. Say in this country, we have an opportunity where perhaps a greater opportunity where the prospect of change is perhaps
We
more
froze here.
accessible. Oh, am I there? Yeah.
Yeah.
But yeah, nothing much more to add than that. But yeah.
All right, well, I think we're at the end of this hour. The one thing I would just add, my internet is unstable. I think this has been a great discussion. I want to say to people, please come up with your goal. Make it a SMART goal. Do one thing between now and the end of the year. And I also want to add and put a little question out there for people, because this is a very scientifically focused panel, but also we need to realize when you're in that country, some of the biggest initiatives and some of the most popular people in the fight against climate change also did not go there just through science. They go there through emotions. So I think we need that multifaceted approach. We need balance, and you know, we need to stay positive because we can do this. So we really hope that you've all appreciated and enjoyed this series. Thanks today to our panelists, Eric, Caleb, and Tina, and Anita, who had to leave us, and to Kaylee and GCCHE, ISPRM, Columbia, Sustain Our Abilities, and hopefully we'll be doing another panel again in the future on this specific topic. Please, you know, save the dates of October 20 to 22. We are going to be online and try to work on making Health and Climate 2023 accessible to people around the world and expand the conversation, not just in rehab, but in all areas of human health and climate change. So have a wonderful day. Thank you all.